So with that, we will move on to our next speaker. Now, requesting Dr. Supratip Kundu to present his talk and requesting all our respected speakers once again to kindly adhere to the time limit so that we can have a happy and well organized listening to all our respected speakers. Thank you and happy learning. Over to Dr. Supratip Kundu. Dr. Kundu, if you can kindly present your screen.
My slides are visible?
Yes, your screen is visible to us. Thank you. If you can kindly make it full screen, that solves the problem. Thank you.
Okay, fine. Let us start. First of all, I would like to thank the organizers for providing me this opportunity. And my topic is heart failure in pregnancy. Without wasting time, I am moving to a topic. As you all know, that pregnancy is a volume overloaded state. And that's why most of the cardiac disease in pregnancy presents with heart failure. Now, first of all, why do we need to consider this entity separately? First, due to increased maternal mortality. Second, due to adverse neonatal and perinatal outcome. Third, heart failure in pregnancy is a heterogeneous entity where each variety presents at a particular time and each variety has a separate prognostic markers. Number 4, one cannot use the all standard drugs of heart failure because of adverse effect of teratogenicity. Fifth, patient may present with shortness of breath even in the late postpartum period. That means at least 5 to 6 months after the delivery. And last of all, in some cases, the pregnancy is absolutely contraindicated. So you need to know those conditions in which pregnancy is contraindicated. Now come to some statistics. Now, as per Western data, heart disease complicates 1 to 2% of pregnancy. Now in India, there is no significant data, but it is just like Western data. And in Western country, the number is relatively stable over decades. And in Western country, generally, in the initial period, there was rheumatic heart disease, which was prevalent, but nowadays it is more of congenital heart disease. Now, around 15% of these heart disease patients present with heart failure, and heart failure causes 9% of death in pregnancy-related hospitalization. And nowadays, in Western countries, cardiomyopathy is the leading cause of heart failure, and due to improved medical condition, in Western countries, increasing number of patients with pre-existing heart disease are encouraged to take pregnancy. But as per Indian data, still 60% patients are newly diagnosed, and the rheumatic heart disease are the most prevalent cause. Major cardiac events occur in 15% of patients, out of which 2/3 is heart failure, and the maternal mortality rate is around 1.9%. Now, what are the defined causes of cardiomyopathy or heart failure? Number 1, defined types of cardiomyopathy like peripartum, dilated, hypertrophic, ARVD, myocarditis, chemotherapy related, or HIV. Second is the congenital heart disease in adult who presents with pregnancy. Number 3 is the arrhythmia. Number 4, ischemic heart disease. Ischemic heart disease is rather uncommon, but there are some incidents of SCAD and some incidents of acute myocardial infarction. Acute myocardial infarction and chronic ischemic heart disease is relatively very rare. Number 5 is a pulmonary hypertension. And last of all, it is valvular heart disease, mainly in the form of rheumatic mitral stenosis or aortic stenosis, mitral regurgitation or aortic regurgitation. Now, coming to pregnancy physiology. What happens in pregnancy? Now, in pregnancy is a volume overload state, and in the first trimester, generally there is sharp rise in the cardiac output. Then from the second trimester, it gradually reaches the plateau, and up to the end of the second trimester, generally the cardiac output increases. Then it becomes a plateau, and then next rise of cardiac output occurs at the time of the labor. That is mainly due to uterine contraction. The plasma volume also increases. So there is also increase in LV dimensions. There is decrease in SVR. So ultimate effect will be decrease in BP. And in the labor, there is increase in cardiac output, increase in the preload due to uterine contractions, and there is increased sympathetic stimulations. And in the early puerperium, the SVR gradually increases and the BP comes to normal level and the cardiac output generally goes down. Now, what is the timing of heart failure? Timing of heart failure, 60% of heart failure occurs in the postpartum period, mainly in the early postpartum period, just after the delivery. 27% occurs at the time of delivery and 13% during pregnancy. Timing of heart failure in mother with known heart disease exhibits bimodal distribution with peak at both 23 to 30 weeks and in the postpartum. Patients with underlying valvular heart disease experiences symptoms throughout the pregnancy, and the peripartum cardiomyopathy generally experience onset weeks before or following the delivery. However, late onset peripartum cardiomyopathy may present up to 12 months. Now, what are the risk factors for heart failure? There are some modifiable risk factors, there are some obstetric risk factors, and there are some comorbidities. Modifiable risk factors are obesity, alcohol and substance abuse, and hyperlipidemia. Obstetric risk factors are eclampsia, preeclampsia, gestational hypertension, gestational diabetes, and placenta previa and abruptio placenta. Comorbidities are hypertension, coronary arteritis, modified WHO class 3 or 4, NOAH greater than 2, or pre-pregnancy heart failure or CKD, and diabetes. Non-modifiable risk factors are black race, age, and anticoagulant use. So let us discuss something about peripartum cardiomyopathy. The timing is last trimester to 6 weeks postpartum, although delayed presentation between 5 to 12 months may be seen, and this late onset is associated with 2 to 3 folds higher maternal mortality. This postpartum cardiomyopathy is less common in Asian but having relatively bad prognosis. It is more common in primipara, and subsequent pregnancy are absolutely contraindicated. So when a patient is having peripartum cardiomyopathy in the first pregnancy, then subsequent pregnancy are totally contraindicated. 72% achieve complete recovery, and there are some adverse prognostic factors like black race, LVF less than 30% at presentations. So, and peripartum cardiomyopathy is mainly caused by hemodynamic changes, significant hormonal changes in pregnancy, and the pro-inflammatory state induced by pregnancy. Now, this is a busy slide. I have taken it from some US data, and this is actually the California Quality Improvement Toolkit on cardiovascular screening and assessment of pregnant mother. Now, if you see that, if you see this slide, you can see that there are three important things. Some factors are red flag factors, some are abnormal physical examinations, and some are moderate risk factors. So when any one of these three is present, that means if there is combination of risk factors, if some abnormal physical findings, or if some red flag signs, then you always do an ECG and NT-proBNP or BNP, and if ECG or NT-proBNP is abnormal, go for TTE. So this is the basic thing of this slide. Now, what are the complications of heart failure? Now, heart failure may lead to increased maternal mortality or morbidity, and in case of children, they may lead to low birth weight, infant respiratory distress syndrome, low Apgar score, prematurity, or mortality. So, what is modified WHO classification of maternal cardiovascular risk? This is very important because in this condition, in class 4 situation, pregnancy is always contraindicated. So you need to remember all these things. Class 4 means Eisenmenger syndrome, LVF less than 30% with NOAH 3 or 4, severe MS, severe symptomatic AS, Marfan with aorta more than 45 millimeter, bicuspid aortic valve with aorta more than 50 millimeter, and native severe coarctation. Class 3 is a mechanical valve, systemic right ventricle, quantum circulation, unrepaired cyanotic congenital heart disease, Marfan with aorta 40 to 45 millimeter, and bicuspid aortic valve with aorta 45 to 50 millimeter. So in class 4 pregnancy is absolutely contraindicated. Class 3 pregnancy is very high risk. So prosthetic heart valve has significant effect on pregnancy. Class 2 to 3, these are the conditions where you can continue pregnancy. Mild left ventricular impairment, hypertrophic cardiomyopathy, Marfan syndrome without aortic dilatation, aorta less than 45 millimeter, and repaired coarctation. Class 2 is unrepaired left to right shunt or repaired tetralogy of Fallot. And class 1 is mild PS, MVP, or repaired left to right shunt. So, what is the principle of management? First, rule out the reversible cause like infection, anemia, thyrotoxicosis, eclampsia, preeclampsia, all these things. Second, assess fetal viability and maturity. Consider steroid if you think to deliver early. Fourth, avoid teratogenic drug like ACE inhibitors, some beta blockers like atenolol, all this, and ARNI, aldactones, and diuretics should be used cautiously because these often lead to low birth weight BP. BP control should be done with dedicated medicines like labetalol, nifedipine, or alpha-methyl dopa, hydralazine, etc., etc. If the patient is in cardiogenic shock or severe heart failure, transfer to tertiary care center for mechanical support. Sixth, option of AICD should be deferred in medically managed heart failure postpartum patients because often they tend to improve. And number 7, 1 week addition of bromocriptine improves chance of recovery in peripartum cardiomyopathy as per 2017 trial data. Now, delivery consideration for stable heart failure patients, vaginal delivery with epidural anesthesia is preferred. Instrumentation to cut short second stage of labor. Invasive hemodynamic monitoring is used to monitor labor and delivery, and postpartum cardiorespiratory monitoring is needed. Lactations and nursing, and mothers with severe heart failure with NOAH class 3 or 4 are advised not to breastfeed. Currently, ACI, ARB, ARNI, MRA, beta blockers, and diuretics are contraindicated. Proper counseling is needed. For mechanical circulatory support, LV Impella with EF less than 15%. In small study, ECMO is beneficial. Discharge recommendation, initiation and optimization of GTMT, identification of the cause of heart failure, identification for barriers to care, assessment of volume status, renal function and electrolytes, management of comorbid condition, heart failure education about self-care, and ensuring appropriate follow-up care and appropriate contraception counseling is needed. So last of all, I would like to end with this trial name, which known as, it is a prospective study known as Healthy Outcome of Pregnancy for Everyone. And this is done in the COVID era with all pregnant mothers, and it is we are hoping to get some new data from this. Thank you.